Nishi there? Acha, okay. Dr. Kudlu is there, Dr. Yuti is there, Dr. Narendra Kumar Taneja, yes, he's there, Deepak Mishra and Kavya Bansal. Kavya Bansal is not there. So, yeah, we will start with the second speaker, Dr. Krishna Prasad Kudlu. He needs no introduction, and he is from Karnataka, a very high volume, especially refractive surgeon and anterior segment surgery. So he is going to speak on Know Your Biometry.
Thank you, sir. Respected chairperson. So I'll be talking about Know Your Biometry. No financial disclosure for this particular talk. Just for the introduction, measuring various dimensions of the eye, its components and their interrelationships, and using this data to determine the ideal intraocular lens power. Basically, biometry consists of keratometry reading and the axial length of the eye. So if you go to any of the literature, probably claims relating to the biometric error or wrong IOL power were almost second most frequent cause of claims and result in payment damage of almost 62% of the closed cases. So coming to the keratometry, basically it is used to measure the corneal curvature. We have to do before axial length measurement. There are two types of keratometer. One is manual keratometer, auto keratometer, and also with the help of topography, either with the placido disc or elevation based, you can know the keratometry. So manual keratometry, two principles, basically fixed object and variable image size, and also with the fixed image and the variable object size. Coming to the automated keratometer, most of us using this, the principle is it focuses the reflected corneal image from the central 3 mm zone onto an electronic photosensitive device which instantly records the size and computes the central 3 mm zone of radius of curvature. So coming to the axial lens measurement, there are two types you can measure. One is with the optical and one with the ultrasound. So coming to the basic principle of ultrasound scan, it has got a piezoelectric crystal that electrically emits and receives the high frequency sound wave. Normally, it measures from the anterior corneal surface to the internal limiting membrane of the retina. If you make a 1 mm error, that means it's almost like 2.5 diopters of error in the postoperative refraction. So, to tip for accurate measurement of the axial length, always make sure that machine has to be calibrated very well. Always you should look for the echoes from the cornea, anterior and posterior lens, and also retina should be present in the very good amplitude. Always you should take minimum of 5 to 10 readings is very, very important. So there are difficult situations where you may have a gain, that is especially in case of you have to increase the gain in case of dense cataract, or you may have to decrease the gain in case of silicon filled eyes and also in the pseudophakic eyes. To do a better results with the ultrasound, we have got a immersion technique where it can be normally patient has to be lie down or can be performed in the standard ophthalmic chair which is reclined at 45 degree using either oceaning or Prager cell. But it takes some more time for this one. There are few I think condition where you may have a inadequate fixation like low vision, nystagmus, strabismus. So coming to the one or two word about the posterior staphyloma, it causes a irregular shape of the ocular wall. So you may find a little difficult to get the axial length exactly. Coming to the silicon oil, because in the silicon oil, this low sound velocity can result in pronounced sound attenuation, and sometimes you may find very difficulty to find a retinal spike. So coming to my talk today about the how this has been grown from 500 to 700. Basically, it works on the different parameters. This first source biometry. So normally this IOL Master 500 works on the partial coherence interferometry. Coming with the IOL Master 700, it normally works on the swift source biometry. So it do almost 2000 scans per second. So it works on these parameters, very, very important. It take into account of axial length, anterior chamber depth, lens thickness, central corneal thickness, very important white to white keratometry, and someone who got a cataract eye suit, it can even guide for a markerless system with the Callisto. So very important is pupillometry also. It even know the pupillometry. So this is about the specification. I will not talk much about this, but very important, as I said, that 7 parameters: axial length, central corneal power, lens thickness, AC depth, white to white, age of the patient. It takes age of the patient, and also very important, previous refraction. So this how it gives. If you see the foveal pit in green, this one, that means there is a good fixation. But if there is, you cannot see the foveal pit, that means there is a poor fixation. So I'll just show you how exactly, if you see with a good fixation, see for the, always see for the foveal pit. And there is a only difference of, if you see the axial length measurement, only difference of 10 micron difference in the axial length, and only 0.02 diopter difference in the keratometry. This you have to always look into that. If you see here, there is a poor fixation, no foveal pit. That means there is already more than 190 micron difference in the axial length and more than 0.5 diopter difference in the keratometry. That means these readings are not accurate. Not only doing the scanning is important, you need to look at the every parameters. So now the thing is, most of the patient comes with the post-refractive surgery. Normally, if you got, this has got a fully integrated Barrett suit, so with that you can get into the all the formulas and the results are going to be very, very accurate. So the one more advantage of this machine, if you see here, mature cataract, white intumescent cataract, even 99% of the cataract it can penetrate very well. Even if you think about doing a premium surgery with of in a mature cataract, that really gives a more accurate results. And you can give a indication for macular pathology. You can just refer to the retina surgeon for a further evaluation. Overall outcome of the results is going to be the best. You can even pick up something like diagnosed like macular pucker. This is very, very important, especially even though this machine is for anterior-segmental cataract surgery, it could be able to pick up some of the retinal condition. And all 4 generation formulas are also there in this, from the Holiday 1, Hoffer Q, SRKT, Hegisen, Holiday 2 Barrett's, all incorporated into this. So then one more thing is, it is also very good for the toric IOL power calculation. So this is about the how exactly it do. See, if you see like less than 45 seconds, both the measurement will be done, and you need to always look for how exactly it does. Even with the green tick, then it measures the, it takes the points into consideration. Immediately, if the readings will come. So less than 45 seconds for both the eyes. So when you are doing, also ask the patient to see straight. Always whenever I am doing my premium surgery, I always look at the, even look at the dry eye status and then go ahead with the results. So coming to the workflow, even I do have got a cataract markerless system. With the toric workflow, you can, the data can transfer from the IOL Master 700 to the Callisto eye. So these are few limitations with the dense cataract. Sometimes you may find little difficulty in this, but it is also expensive. In summary, overall it get a fewer, very less refractive surprise. It improves your refractive outcome and optimize your workflow. In conclusion, due diligence has to be undertaken during the biometry to prevent post-operative refractive surprises. A proper history, use of optical biometry and also specific formula is utmost importance. In customization of the cataract surgery, biometry is primary. Thank you, and all for the opportunity.
So in toric cases also you use this machine,
Yeah.
the Barrett toric formula you are
Yeah.
seeing. So what difference did you find with these machines? You said the lens thickness also it can
Yeah.
be seen. So do you keep changing the IOL power calculation whenever there is an intumescent cataract with the antechamber depth is low in this eye and the other eye antechamber depth is more? So do you take the exact calculation what the machine gives, or you keep
No, I
changing
take
it?
the exact calculation whatever the machine gives. But seeing the lens thickness, it will be more useful when you are doing phaco. Because see, if you think that the lens thickness is very thick, then you may have to normally, I see the AC depth also. AC depth is shallow and lens thickness is more. Normally, I take a more preventive measures like taking a high viscoelastic while doing the phaco. That gives the more result. But I will not be changing any of the parameters as far as the result is concerned.
So this is the problem. What happens in the IOL Master 700 is the intumescent cataract, it effective lens position, it calculates as if the lens is much anterior. But after the surgery, the lens goes
That
back
is the
and
one
then,
thing.
yeah, the patient goes into hyperope. So we need to,
That is the one thing, effective lens position, you have to also keep it in mind.
yeah, thank you, Kudlu.
Thank you, Dr.
May I ask Dr. Mamta Podar? So she'll be talking on phacoemulsification, cataract with coloboma and pupilloplasty techniques.
Good evening, everyone. Today I am going to share my experience of coloboma with cataract and pupilloplasty. So, any anomaly during the closure of embryonic fissure will lead to formation of coloboma, and these patients develop cataract early in their life. So, what makes it a
Can you
challenging
please
surgery?
be close to the mic? Yeah.
So what makes it a challenging surgery? The presence of microcornea, non-dilating pupil, difficult rhexis, and absent or weak zonules. So dealing with challenges, coming to the microcornea, so if the corneal diameter is more than 8 mm and if it is a soft cataract, then our first choice should be phacoemulsification. And if the corneal diameter is small, means it is less than 8 mm with high grade of cataract, then we should prefer SICS. And if you want to go for phacoemulsification, we can make a sclerocorneal tunnel. And if it is very high grade cataract, then we should go for ECCE. Non-dilating pupil, there are many ways to deal with this situation. We can go for mechanical pupilloplasty, dilating drugs, or B-hex ring. No difficulty in CCC, as the stretch of zonules is not equal all over the capsule, so the chances of rhexis going out is always high. For this, we can use micro-rhexis forceps. Now, zonular weakness. Because of this weakness or the absence of zonules, there are chances that there will be communication of anterior chamber with the vitreous. So, if trypan blue goes behind, then it will stain vitreous, and due to this, we will lose our fundal glow, and we will have to perform our whole surgery in a dark room-like situation. And if fluid misdirection happens, then it will lead to the swelling of vitreous. There will be upthrust of vitreous, which can increase the zonular dialysis. It can lead to PCR, endothelial damage, or descemet membrane detachment. This was my one surgery when vitreous was stained, and I had to perform whole of my surgery in a dark room-like situation. This is a post-op. We can see that vitreous is looking blue here. So what to do here? So if there is good fundal glow, then we can avoid putting trypan blue, and if it is indicated, then we can use it in a diluted form. Now our aim is to decrease stress over the zonules. For this, we can use CTR. We can put good amount of visco so that it will coat the weak area, and the communication between the anterior chamber and vitreous will be blocked, and there will be no misdirection of fluid. We can also decrease phacoparameters, and we should maintain the anterior chamber throughout the surgery so that there should be no fluctuation and no stress over the zonules. Coming to the surgery, while I was raising my capsular flap, I noticed the lots of wrinkling. So it was a clear indication that my rhexis will not be complete by using the casual cystotome. So I have used this microrhexis forceps, and I have holded the base of flap very accurately, and in this way I was able to complete my CCC in a very controlled way. So after completing this CCC, I have put the CTR after doing the hydrodissection. And since it was a soft cataract, so phacoaspiration was sufficient. And the cortex at the site of dialysis was removed in the last, and that too in a very controlled and in an extremely gentle manner. So in this way, I was able to finish this surgery. IOL was inserted, and this is the first post-op day. Patient was perfectly fine. Now coming to my second presentation, that is pupilloplasty. I will be discussing about the single pass 4-throw technique, also known as Dr. Amar Agrawal technique. So this was one case. He was aphakic. There was this is his pupil diameter, and there was total loss of iris tissue from this part. So after doing this pupilloplasty, I have implanted ACIOL over it. Iris glow was not possible as there was no iris tissue here. So there are many techniques, surgical and non-surgical. Non-surgical is basically done in cases of multifocal IOL when the pupil is decentered. Surgical technique, this Amar Agrawal technique is easy to learn. Even I was able to perform this technique in my first case. So, but aim of the all technique is the restoration of pupil size and centration of pupil. Why it is needed? Because patient suffers from halos, photophobia, blurry vision, headache. There are lots of indication for pupilloplasty. I am not going into the details. The contraindications are phakic eye with clear lens, because there are chances that we will touch the lens and it will lead to cataract formation in case of atrophic iris. These are the complications. So what actually we do is that this is another case with coloboma, and this is the pupil size, and this is the colobomatous zone, and this is the first post-op day. The pupil is relatively centered and the size has also become decreased. So what we do in this technique, from the one side, we are inserting this 10-0 proline with a straight needle. From the other side, we are inserting the 26 gauge needle, and by the railroad technique, we take out this proline suture out, then we make a loop, and after that we put a 4 throws, and after stretching the opposite ends, we get a knot at a desired part. So in this video, we can see from one side, I have put this straight needle, proline 10-0, and this side it is the 26 gauge needle, and this proline is taken out to the other side, and after making a loop, putting the 4 throws, I was able to perform the pupilloplasty. Thank you.
Thank you, Dr. Mamta, for these nice video of such a complicated cases. So thank you very much.
Now, Dr. Mamta, what is the size of the IOL you prefer in these microcorneas? Do you have any specific thing, or you put the same size IOL in these patients?
Sir, means I check, means ACIOL, I have to decrease the power by 0.5 like this.
Size of the IOL.
Oh, you are talking about the optic size? Oh, no, sir. Means, the regular which. Yes, sir, I am doing with the same regular size.
So if there is only an inferior coloboma of the choroid,
Yes, sir.
when there is a coloboma of the iris,
Yes, sir.
only inferior coloboma there, your journals are good. Do you prefer to put a multifocal in this patient?
No, sir, I have put only monofocal, because in the cases of coloboma, there are high chances that one eye is already compromised. Because if the coloboma extends to retina and choroid and optic disc, then we are left, in my cases, I was left with the one eye only. So, I didn't take any risk, and I went for the monofocal only.
Okay, thank you.
Okay, thank you so much.
Next, I'm going to invite Dr. Vibhuti Prasanna Sinha, the organizing secretary of this wonderful event. Thank you, Vibhuti, for organizing such a nice conference. So, Dr. Vibhuti will be talking on wiping out the wipeout phenomenon, tips for prevention. Dr. Vibhuti, please.
Hello. Thank you, sir, for giving me this opportunity. I'll be talking on, in a brief, how to wipe out the wipeout phenomena and what are the tips. Having said that, most of the surgeons don't prefer to operate upon a trabeculectomy even in cases which are very advanced, just because of the fear of losing the sight, whatever reason the patient has. But in my take is, you have to take chance if you want your patient to survive for a little longer. That's the only situation, and you have to do. So this is also known as snuff syndrome, rare yet possible complications. It is very rare. I mean, from 1% to 13% is the chances of occurrence, and usually seen in patients who are very advanced at the stage 4 or stage 5 glaucoma. So defined as a permanently early post-operative irreversible reduction of the visual acuity to less than 6/20/200 or to the counting finger or less if pre-operative vision was below 20/200. Or if you see that wipeout phenomena, if there is a loss of central visual field with a retinal sensitivity measuring 0 decibel in 4 points abutting fixation on both the central 10-2 and macroreal threshold program, that is wipeout phenomena. So you can see these are the cases like very advanced kind of the glaucomatous damage, or the patient where there is some amount of changes in the 10-2 macular program. These are the patients who are very prone to developing this wipeout phenomena. So incidence is, as I said, less than 1% to 13%. The chances of occurrence is there. There are various prospective as well as retrospective studies, and which presents various incidents in these cases. However, having said that, the chances is always there. So what are the risk factors? The risk factors are the old age with the high preoperative IOP, preoperative split fixation, choroidal effusion, retrobulbar and peribulbar anesthesia, undiagnosed high IOP. So one of the most important thing is the patient with a very high IOP whom you are operating and sudden decompression is there, or when you operate upon and the patient is left with a shallow chamber for a little longer period, and that can lead to some amount of the choroidal effusion or a very turbulent post-operative phase. These all three conditions can develop into the wipeout phenomena. Having said that, this is very rare phenomena. There are other chances also with local anesthesia. Direct trauma can occur to the pressure to the nerve, since we know that very few fibers are left. Even the macular fiber is a split sometimes, so there are very few fibers, and if you leave the patient even with a slight increase in the IOP a little longer for the little longer time, that can damage localized pressure to the optic nerve or the volume of anesthesia if you trap them within the facial layers, leading to the compartmental syndromes. Adrenaline in local anesthesia again can be a vasoconstrictor and can create some kind of problem. Even hyaluronidase is associated with orbitopathy and optic neuropathy, and they can result into the damage. Then pressure spikes in the intraoperative as well as the postoperative phase. If you have sutured the scleral flap very tightly or fistula blocked with iris tissue, or you leave the viscoelastic into the anterior chamber in these patients, and in the post-operative phase, if the IOP is very high, that this can lead to a split kind of the fixation. So etiopathogenesis are associated with the occurrence of sudden intraoperative ocular hypotony during the glaucoma surgery, or optic nerve hemorrhage, or microembolic episodes. So post-operative hypotony with choroidal effusion can be an independent risk factor in one of the studies. So preventing hypotony is very important. Timing of release of the releasable suture is also very important in these cases, so as to titrate the IOP in the post-operative cases. So advanced visual field defect affect the central field with a split fixation. So what are the things which we should do? Pre-operative evaluation, a good pre-operative evaluation and the risk analysis has to be performed to identify if there is any risk factor associated with this patient that can result into some kind of the wipeout phenomena. Patient presentation and unexplained decreased visual acuity more than 2 lines on a Snellen's chart, or duration first 2 weeks post-operatively and persisted for 3 months. The post-operative evaluation is very important in trabeculectomy patient. First post-operative day, day 7. If the patient has some kind of high IOP or lower side of IOP, then naturally you have to keep the patient on a regular follow-up, visual acuity and IOP in all fields, visual field management, visual field assessment at the 3 months, and the use of the 4 central visual field in addition to the mean deviation is very important. So to do things are, to note any early undiagnosed post-operative IOP spike. IOP should be monitored few hours even after the surgery. And in these cases who are at very prone, since the patient has already that advanced kind of the glaucoma, so it has to be monitored. Controlled IOP preoperatively, use of subtenonal anesthesia is good. Avoid use of adrenaline in such patients. You can always use brimonidine in the early before the surgery so as to prevent the bleeding. Use of antimetabolite to reduce the subconjunctival scarring and the failures can be reduced. Use of ACM is also one way to decrease the chances of occurrence of the sallow AC during the intraoperative phase. Or what is important if you do a trabeculectomy and you come out without ever changing the depth of the anterior chamber, so that is the best situation. And always take out the viscoelastic from the anterior chamber at the end of the surgery so that the post-operative complication doesn't occur. So this is all about the wipeout phenomena which I want to say. There are a few more slides which I would like to skip. Thank you very much, sir.
Thanks, Vibhuti, for these nice tips. Thank you very much. So, may I now invite Professor Narendra Kumar Taneja. As we have been handed over the hall late, so we will first try to cover all the presentations, and then we will take up the questions as the time allows. Nani, you are there. Yes, sure.
I will talk about our doctors, vaccination and preventing vaccine-preventable diseases. One of the vaccines is pneumococcal vaccines. There are two types of pneumococcal vaccines. One is pneumococcal polysaccharide vaccine. This is a short-acting and T-cell independent vaccines. And second is pneumococcal conjugate vaccine or PCV. This is a long-acting vaccine and gives mucosal immunity. There are 4 different types of vaccines: PCV 10, 13, 15 and 20. PCV 13 has been the commonest available in India, and only 1 dose is given in life for adults. However, whenever the Prevnar 20 becomes available, this can be given. In normal persons above the age of 50 years, for we ophthalmologists, our families, everyone should get a single dose of these vaccines. And persons below the age of 50 years with immune suppression, PCV 13 is given 1 dose, and this is followed by a dose of PPSV 23 after 8 weeks and 5 years. PCV 10 is used in children. PCV 15 is being developed in India by Serum Institute of India. PPSV 23, this has 23 different strains of pneumococci. Immunity lasts 5 to 10 years. 19 to 50 years with comorbidities, single dose is given. 19 to 50 years with immune suppression, 2 doses after a dose of PCV 13. And after 65, 1 dose is reserved for person above 65. Only 3 doses can be given in life. Flu and typhoid vaccines. Flu, this is an inactivated tetravalent vaccine, 0.5 ml given intramuscularly. For all, dose is same for children, small children, 6 months, and for all others, healthcare workers, pregnant women, and those with comorbidities. Typhoid conjugate vaccine, most cost-effective vaccine, only single dose is given throughout life. Same dose, 0.5 ml for adults as well as for child of 6 months of age. Measles, mumps and rubella. This concerns of ophthalmologists also. This is a live attenuated vaccine. This should be given in preconception period or to adolescent girls to prevent congenital rubella syndrome. At least 1 dose should be given, and pregnancy should be avoided for 1 month after that. All healthcare workers, including we should get 2 doses 1 month apart. MMR can be replaced by MR or RVAC. Coming to hepatitis A vaccine, there are 2 different types of vaccines. Killed vaccine, 2 doses are given. In children, half ml, and adults, 1 ml. And second is a live attenuated vaccine. Single dose is given 0.5 ml. Same dose for children, small children, as well as for adults. All adults, all healthcare workers, all doctors, they should get it if not given in childhood. So if a person is immune compromised, only killed vaccine should be used. Hepatitis B, 3 doses are given at 0, 1 and 6 months if you did not get it in childhood. Boosters, they are not recommended routinely. However, post 50 years of age, one can get a booster or one can get IgG level checked. If they are below 10, then one can go for booster. Chickenpox or varicella vaccine. Dr. Jyoti Biswas showed slides of this choroiditis or retinitis caused by this zoster virus. This is live attenuated vaccine. 2 doses are given in adults, 4 to 8 weeks apart. All adults, all doctors, all healthcare workers, they should get it. If they did not get it in childhood or did not have chickenpox, then all the contacts of the herpes zoster ophthalmicus patients, they should also be advised this vaccine. Then coming to shingles or the zoster vaccine. This is a different vaccine from this varicella vaccine. This is a high potency vaccine. 2 doses are given in persons above the age of 50 years to prevent herpes zoster. Tdap. Many of us may not have heard this name Tdap. This contains reduced dosage of diphtheria and acellular type of pertussis component and full dose of the tetanus vaccine. This can be used above the age of 7 years. Tdap is used every 10 years till the age of 65 years, after the age of 10 years. In pregnancy, this vaccine, one dose is must in pregnancy, and all healthcare workers, they should get this vaccine. Then coming to rabies killed vaccine, all of us should get the vaccine pre-exposures, because once we are going outside, the dogs are everywhere and we may be bitten by a dog at any place, and vaccines and the antibodies, they are not available everywhere. So 3 doses are given pre-exposures, and if a dog bites, then after that only 2 doses are required and no antibodies are needed. All doctors, they should get it. Post-exposure 5 doses are given plus antibodies if it is a class 3 bite. Human papilloma virus vaccine. There are 2 different types of vaccine, 4-valent and 9-valent. This prevents cervical, genital, oral, anal, head and neck cancers and genital warts. Recently, Cervavac vaccine has been developed by Serum Institute of India, and this will be available in National Immunization Schedule this year. The Government of India is buying 16 crore vaccines. At present, Gardasil 4 costs 3,000 rupees, while Gardasil 9 costs 8,500. This is after reduced price after the introduction of Cervavac. 9 to 14 year 2 doses, and above that 15 to 26 year 3 doses. 2-valent vaccine which was being used has become obsolete now. In pregnancy, at least 1 dose of Tdap, and second dose can be of Td, 1 month before or after Tdap, and plus flu vaccine. Coming to vaccinations for adolescents or young adults or preconception period.
Professor Taneja, please try to sum up.
Yes, sir. The last 2 slides, sir. Sure. Preconception period, MMR, flu, typhoid, hepatitis A and B, varicella, human papillomavirus, and Tdap. In adults, TCV, flu, PCV, PPSV23, varicella, hepatitis A and B, MMR, Tdap, zoster, rabies, human papillomavirus, and Japanese encephalitis in endemic areas. Special situation, cholera, yellow fever, MCV, Japanese encephalitis. Thank you, sir.
Thank you, Dr. Taneja. So, now we are going to have the last talk of the evening by none other than Dr. Deepak Mishra. He is going to talk on setting up a wet lab. It's a very important, especially for our PG teaching and research works. So, Dr. Deepak Mishra, please.
Respected Chairperson and delegates, there is no financial interest in my talk. First of all, why it is important? The wet lab is important because it is the building block of any surgeon's career. Whatever the skill we learn or we acquire from anybody, if we are doing it in wet lab, it will be much more faster. It helps us to attain some skill, develop hand-eye coordination, as we all know. And apart from these two things, which is the most important, is it gives a chance to practice without any risk, or we can say it is a risk-free environment training in which there is no risk for the patient, or even the whatever the changes or the mental changes anyone going to operate first on a live subject is very less when he or she has been trained under the wet lab. So in the setting of wet lab, four things is important. First is the space. Second is the requirement. Again, requirement depends upon two things. What are the consumables or the equipment required for that course, curriculum and cost. I will cover my talk only on these four parts. Space, basically what we suggest that in a wet lab, the space should be located in the main building of the medical college or the department, so that the resident have access every time, because in the working hour most of the time residents are busy in OPD and another places, so they can do their wet lab practice in after the rounds in the evening or the early morning, whenever is the required. And at least it should have a space for two people. One is for sitting, and if two or three residents are doing, or one trainer is there who can train them in a two places. This is the ideal size of the wet lab. Means if you go by 10 feet and 10 feet room, that is more than enough. You can see this is my setting of wet lab, and diagram is from my IOS skill transfer courses. Here we can have each and everything, a slit lamp, and if we wish to have a monitor for being another one, and two revolving stools are important because these tables cannot move up and down, so only we have option for moving up and down this stool and this microscope. And this is the original photograph which you have seen mostly in the IOS we are doing it. Here you have seen this is a simple changes. If anyone wish to change, this side will be the instructor and here will be the trainee who can easily do the wet lab in it. If space is not available to make cubicle for everywhere, if for a big conferences or anywhere, even we can have a continuous spacing, but we have to remember that there should be a spacing between two tables that they will not disturb each other. Now coming to the consumables. Consumables basically depend upon the two things. One is the nature and type of surgery. Another is the number of the person or the trainees in your department or anywhere. These are the simple consumables. Anyone, all of the teachers can guide which type of things is required for what. So I am leaving it. And these are the common materials used for the wet lab. All these are the photographs taken. This is, although it is very light, but here you have seen that these are the sutures placed on the thermocol. Even you can place on the banana, these eyes, and these are the nowadays wax eyes available in India for doing the phaco. Equipment, at least I suggest that one microscope, either new or old or any one, it is table mounted or not table mounted. Nowadays many Ambala made companies also giving the microscope table mounted on the very low cost, and that will be used for training each and every institution. I am remember one thing important for these requirement is that if any place where we can have a thermocol box or ice cold box, because these goat size are very friable. So if we store them in a cold box, then it is built, it is having good corneal clarity for doing the surgeries. And another thing is, whatever the thing is available, at least we have some sink and tap near about that, because goat size are having higher risk of transmission of hepatitis C. So even the trainees and trainers should wear gloves, and we recommend regular washing of hands. This is the eye fixating device available for the phaco. Here you have seen these are the wax eyes used for the phaco, and we can also have a goat eye fixator also available. All these, this is, if no one is available, then we can simply fix the goat eye with the pin, and here you have seen this micropore for doing the surgeries. Nowadays we have with relation with, there is no financial interest, but Madhu instrument make an vertical holding of this goat eye stands by which anyone can do a planation or the gonio. We are using it in the GSI conference. And there is a wet lab curriculum. This is the must. We design it, and whatever the wet lab expectation from the curriculum is that in the first year at least the student who are she is there, she is able, he or she able to put at least do some thermocol suturing on the wet lab. That is the most important step, and I hope all the seniors must go by with that suturing in the wet lab or thermocol anywhere somewhere in the gloves is the most important. So at least the first year I am for the first year wet lab training the target should be the suturing, and the another for the second year whatever the wound constructions are there for the SICS or trab anything should be done by in the second year. And at the end of third year if he or she are interested in FACO, then at least know all the parameters required for the bottle height, vacuum and this year. These are the three different curriculums for the wet lab for the first year, second year and third year. Nowadays simulators are also available, but only drawback is they are very costly, nearly 2 to 4 crores costing for the both simulators. I am skipping this cost, but one thing I can say that most of the institutions or the teachers when they met me they said that wet lab is costly, but I am truly saying wet lab is not costly at all. There are many companies who are giving us an opportunity to buy the sterile free things, sterile free sutures, gloves, visco, everything, and that are the much more, almost 1/10 of the cost as compared to the sterilized sutures. So there is no need of buying whatever we are buying for the patient. For the wet lab, sterile free sutures and even the open gloves we are usually using it, it hardly costs much, I think 1/10 of the cost of the original gloves. So by this we can do wet lab. These are the our articles in which we have demonstrated each and every points how to set up a wet lab in an institute, medical college or anyone. If anyone interested, I will give it. With these regards, just only thing is have a proper planning and believe that this planning is by you all, means the mentors who can plan their wet lab for their own candidates. There is no issue of fund wet lab at all. Only thing required is the knowledge of the mentor and the willpower of the institution that they wish to do for their residents. Thank you, sir. Thank you.
Wet lab, and I really sincerely appreciate and I recognize your contribution to AIOS, especially PGTs and the skill transfer programs. Thank you very
sir.
much.
Thank you, sir.
So,
Any question?
any question, any
Sir, I want to ask a question to Dr. Krishna Prasad.
Sir,
Krishna Prasad is not there. He had some other
he had
commitments
some
in
another
other
kind.
session.
He's moderator.
He was a
there.
moderator in his other session, that's why.
Sir, I got a case where the different institute have different IL power for cataract case. So we planned for multifocal, toric multifocal. So what should we do if a different machine gives different IL power? So which one should be taken, whether IL master or?
So in our experience, what we do is we keep doing on one machine and then standardize our putting the IOL powers and then calculate and then see. Don't measure two instruments, different instruments which you are not aware of and then get confused. So the machine what you are doing, you have your post-op results on 100 patients with a similar eye, with a similar surgeon, and then with a similar no complications, and then standardize that and then use them. So even if there is a difference with other scan, forget about it. The machine what you are using, what you are standardized, you need to do that.
And from time to time, you have to calibrate also. You have to check the other settings and all. And of course, I agree with Dr. Sharad, you just don't go on changing the machines. You try to be more, because in which you are comfortable.
And in these machines, when you take the scan is more important before dilatation without putting as a virgin eye, without putting any drops in the eye, you need to do all the scans before itself. So those
Undilated,
things
in
give you
undilated
the reliable,
condition.
the keratometry and all the excellent scans.
There are other factors also. Suppose the person who is doing the biometry and that keeps changing. You have to. There are so many factors, you know. Not only machine, the person also working on the machine. So thank you very
We
much.
can have a group photograph and finish.
हाँ just a minute. Let us have a group photograph. I think most of the speakers have already gone. But yes. Especially some of the talks were so, Dr. Deepak, I wish it should have been in some more premium time. Yeah.